Hi, welcome back. Today's topic of discussion is about one of the bones of the forearm, which is, if you can already recognize it, congratulations, radius. Right? So, without wasting any time, let's quickly delve into the topic, see as to the bony features of radius, then the different attachments of the radius, a little bit about its clinical anatomy. It's just the usual stuff in which we actually delve with the bones. That's how we deal with the bones. So, as far as the radius is concerned, one of the very first things that actually came into my mind, as far as questions are concerned, is why is it named radius? So, I found out that this is named radius in accordance to the radius of a circle. So, that's the reason why it's known as a radius. Why? Why is it the radius of a circle? It's because during the pronation and supination of the forearm, when we're doing like this, pronation and supination, the radius is actually rotating around the ulna, right? The ulna tends to remain fixed, whereas the radius tends to rotate around it, right? So that's why radius seems to be actually kind of a homage to that, as if it's rotating around in a circle, and that's why radius, that is the distance from the center to any point on the circumference of the circle, right? So in that sense, it's actually known as the radius. So let's first talk about the bony features of this radius. As we can all see, this is the upper end of the radius and this is the lower end of the radius. Very, very distinct. See, the upper end is very distinct, as it is, as you can all see, rounded and ring shaped like this, right? So it has this very beautifully shaped head, which seems to have a concave depression over here with this neck around it, right? So the entire structure is very ring shaped structure, the upper end, whereas the lower end, on the other hand, is pretty expanded with this protruding tip or process, which is known as the styloid process, right? Let's talk about this systematically. So let's first talk about the upper end. So I said that this is the head and this is the neck, right? So obviously we know that the radius will be articulating with the capitulum of the humerus, right? And the articulating surface for the radius is this concave head of the radius. Okay, now what attachment does this neck and the head actually have? This head and neck, what do they have actually? As far as attachments are concerned, they are attaching the annular ligament. So I said that this is ring shaped, and see, annular ligament, annulus means ring. So a ring shaped ligament, suppose this is the annular ligament, actually holds the radius along with its head and a little part of its neck as well, right? Now as far as the capsular ligament of the elbow joint is concerned, radius, the head and neck, they do not attach to the capsular ligament. They do not give attachment to the capsular ligament. They are free from the capsular ligament. They are bounded only by the annular ligament and to the radial notch on the ulna, which is somewhat like this. If I show you now, disclaimer, these are opposite sided, all right? So this is the left, this is the left sided radius. I'll talk about side determination, don't worry. And this is the right sided ulna. I didn't have a homologous same sided radius and ulna, but for all intents and purposes, this should suffice. So as you can see, there is a notch in the upper end of the ulna. This is a notch present over here. This is the radial notch. So the radius seems to be somewhat, articulating like this, and the two ends of this notch will actually give attachment to the annular ligament. So radius is somewhat pinned against the ulna with the annular ligament attachment, all right? So that's the upper end accounted for. Then very beautifully enough, we see a beautiful tuberosity over here. See, It has a smooth anterior part and a very rough posterior part. This beautiful tuberosity that I talk about, this is the radial tuberosity. I don't know why I said beautiful. I guess it is beautiful in a sense. You just need the eyes for it. So this is the radial tuberosity. Alright. Now radial tuberosity, since we just talked about the head and neck, so radial tuberosity must be closer to the upper end. So that is also a very important site determination feature that I just said. And as I mentioned, that the radial tuberosity has a smooth anterior part and a rough posterior part. Alright, we are not talking about the attachments, or should we talk about it? Alright, let's talk about it. The radial tuberosity, as you can see, in its rough posterior part will give attachment to the biceps brachii. It will actually give insertion to the tendon of biceps brachii. Smooth anterior part does not give insertion to any muscle as such, but it does give attachment to a bursa. So the bursa associated with the smooth anterior part, the muscle associated with the rough posterior part. That is the radial tuberosity accounted for. So that is also serving as kind of a site determination feature, because as you can see, this is the anterior part, the smooth part rather, sorry. Hence you deduce that this is the anterior part, and this is the posterior part of the radial tuberosity, must be the posterior part. So this is the anterior and this is the posterior, so this should be the orientation. This is the upper end. Now this is the entire shaft of the radius. As you can very well see, the shaft has 3 borders, 3 surfaces. Such is the story of probably every long bone in our body. So the first border that we talk about is the anterior border. This is the anterior border. Alright. So look very carefully as to the tracing of the anterior border. The anterior border is starting from the radial tuberosity. Then it is extending downwards. In its initial segment, it being obliquely oriented. In its later segment, it being vertically oriented. See? Going. Finally, it is actually ending in this process that I just mentioned, the styloid process. This is the tracing for the anterior border. This initial upper part, it is oblique, as you can see. This oblique part of the anterior line is called the anterior oblique line. Anterior oblique line seems to give attachment to a muscle. That is the radial head of Flexor digitorum superficialis. Alright, the radial head of the Flexor digitorum superficialis, that actually takes origin from the anterior oblique line, and also a bit of the upper part of the anterior vertical border itself. Alright, so it's a bit extensive, not much. This is what I'm talking about. Again, that's the anterior border accounted for, right? Now, obviously there are other borders to account for. So if this is the anterior border, diametrically opposite to it, this is the posterior border. Alright, see, I'm placing the radius now posteriorly oriented. This is the posterior border. Now, a very interesting thing is, why am I tracing posterior border from so below? Why am I not going anywhere above like this? The reason for that is, the posterior border is very much ill-defined in its upper and also in pretty much its lower segments. It is only very well defined in its middle segment. See? Do you see how it is glistening? Yes, this glistening, this brightness, this reflection, this is due to the fact that the posterior border is very, very well defined in its middle 1/3. Over here, this is what I'm talking about. Whereas upwards, not so much. Very much lower, not so much. However, just like the anterior border in its initial upper segment was oblique, posterior border also seems to be going in an oblique way, like this, right? Hence, This part, somewhat ill-defined, is also known as the posterior oblique line. Also, very, very interestingly enough, we say that the posterior border, not oblique line, posterior border of radius is a mirror image of the anterior border of radius. That makes things pretty easy for us. So anterior oblique line, anterior vertical line, similarly a very ill-defined posterior oblique line with a very well-defined in the middle 1/3 posterior vertical line, which is extending downwards. And yeah, this is it. Not much to say about it. Anyways, so I was trying to trace it a little below, and I'm almost compelled to say that it somewhat merges with this tubercle over here, which we'll talk about in a bit, but let's not make any comments. All right, let's not make any comments about that. Let's move on to the third border. So anterior border, posterior border accounted for. The last border, very, very well defined, is the interosseous border. The interosseous border or the medial border. All right. So this, as you can see, very sharply oriented, very sharp. As you can see, this is the medial or the interosseous border. This has a pretty well tracing, a well-defined tracing, if I may. Starting from the radial tuberosity, again, like the anterior border, it also starts from the radial tuberosity, goes down, 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 and finally, it seems to be continuous with the posterior margin. It seems to be continuous with the posterior margin of this triangular impression on the medial surface. This triangular impression, are you seeing? This is the medial surface of the radius. So posterior border of this triangular impression, this is where the medial border actually continues as and finally ends. Right? Right. So that's the interosseous border accounted for. Now, as the name suggests, obviously you can all make this out. Medial border or interosseous border in its lower 3/4 will give attachment to the interosseous membrane. So interosseous membrane is present in between the radius and the ulna, right? So the lower 3/4 will be providing, obviously the interosseous border will be providing attachment to the interosseous membrane. Done? Done. Now let's very quickly talk about the surfaces. In between the anterior surface, I'm sorry, I already ruined the surprise. In between the anterior border and the interosseous border is the anterior surface. That is the surface, anterior surface. So this, see, this is the anterior surface. In between the anterior border and the interosseous border. All right. This anterior surface, we already talked about the anterior oblique line in attachment. Anterior surface attachment, as far as that is concerned, for like its upper 2/3, it will give attachment to a muscle called the Flexor, Pollicis, Longus. The Flexor, Pollicis, Longus. These are all muscles of the forearm. More importantly, flexor compartment of the forearm. So this is the Flexor, Pollicis, Longus accounted for. Whereas in the lower 1/3, in the lower part, this will actually give attachment to the pronator quadratus muscle. All right. So the pronator quadratus muscle from the lower 1/3 of the anterior surface, from somewhat the upper 2/3, the Flexor, Pollicis, Longus. Pretty extensive. All right. That somewhat completes the anterior surface. Now the other surfaces, let's jump on to them. In between, this is the interosseous border and this is the well-defined part of the posterior border. This surface, do you see? This surface is the posterior surface. All right. So if this was the anterior surface, diametrically behind it, see my index finger, I'm actually right now at the posterior surface. Let's check. Yes, I am. So now do you see how the radius is oriented? This is how this becomes the anterior surface, and this is how this becomes the posterior surface. So it's pretty well explained actually. So posterior surface, very well. What are the attachments for it? It's pretty easy. Posterior surface, again, it gives attachment to two muscles, just like the anterior surface did. These two muscles, we'll see that there is a connection between these two muscles. First, let's name them. These two muscles are the abductor pollicis longus and the extensor pollicis brevis. Now, the first connection between these two muscles is, obviously, they are components of the extensor compartment of the forearm. Undoubtedly, no problem in that. I'm trying to be a bit more specific as far as the connection is concerned in saying that they form a part of the boundary of the anatomical snuff box. It's not pretty well evident on my hand, but you pretty much should know where the anatomical snuff box is. So these actually form boundaries for the anatomical snuff box. Part of it actually. A part of the boundary of the anatomical snuff box, the abductor pollicis longus and the extensor pollicis brevis. Both are attached, or both are given attachment by the posterior surface of the radius. That is the posterior surface accounted for. Now, the last remaining surface is in between the anterior border and the posterior border. This surface, this is the lateral surface. See, it makes sense because when the radius is oriented like this is the anterior surface, this is the posterior surface, so this becomes the lateral surface, right? So, lateral surface it is. It is pretty well extensive a surface, and as far as muscle attachments are concerned, the very first muscle to get attached is the supinator, which is pretty well written over here, the supinator. Alright, in its upper part, supinator, somewhat middle part, pronator teres, absolutely lower part, very close to this styloid process, we have the brachioradialis insertion. So there are three muscles which are associated with the lateral surface. In its upper part, pretty extensively, the supinator, middle part, somewhat extensively, the pronator teres, in absolutely the lower part, very close to the styloid process, but not from the tip, obviously, but very close to it nevertheless, but somewhat an extension of the lateral surface, the brachioradialis. Alright, so that takes somewhat all muscles into consideration as far as radius is concerned. Now let's talk about a few more attachments which are not muscular. The very first thing is this green highlighting that has been done over here, very close to and below the radial tuberosity. What is this? This is actually signifying the attachment of the oblique cord. We'll talk about it later when we talk about the joints as such, but this is the attachment for the oblique cord. Where exactly? Close to and actually below the radial tuberosity. Done? Done. Again, something which is not actually given, but I would say is medial to the, or rather on the medial surface of the neck over here. This is the medial surface, or is it? No, this is the lateral surface. What am I doing? This is the medial surface. Yes. How do you check for the medial or lateral? It's pretty simple. First of all, you can check it by the interosseous border, the sharpest border, or the styloid process. The styloid process is obviously inferiorly, duh, and laterally as well. Alright, so this is laterally and inferiorly. So laterally. So this must be the medial part. So medial surface of the neck, that will actually give attachment to another ligament, which is the quadrate ligament. Again, we'll talk about it later. Quadrate ligament over here, oblique cord over here. Done? Done. Interosseous membrane for the most part. Again, another interesting thing which I probably forgot to mention, lower part of the anterior border. Yes, I definitely forgot to mention this. Lower part of the anterior border, that will actually give attachment to the extensor retinaculum. Extensor retinaculum. Alright? So that's another interesting attachment. Again, see, since our scope here is only the osteology section, so we'll only name the attachments and try to understand how they're attached and try to understand the bony features, and we'll be done with it. When we'll be talking about the actual anatomy of the upper limb, gross anatomy section, when we'll be leaving the osteology and delving into the other sections of upper limb, then we'll talk about these structures in details. Alright, that's how this works. So that's the entire shaft, somewhat upper and the entire shaft covered. Now let's come to the lower end. Yes, the lower end also has a few things going for it. As you see, or rather as I already mentioned, the lateral part inferiorly, it is forming the styloid process, as I mentioned. As far as the lower end itself is concerned, it is pretty expanded and it has 5 sides. This is the anterior side, or rather 5 surfaces if you may. Anterior surface, this is the medial surface, this triangular impression with a notch over here, which is the ulnar notch. So the medial surface of the lower end will bear not only this triangular impression, but also the ulnar notch. By the way, now that I remember that I mentioned that pronator quadratus was actually attached onto the lower part of the anterior surface. Well, it turns out that the attachment also seeps on to a bit of the medial surface of the lower end in the triangular impression as well, as is very evident from the drawing over here. So that is one point that I had forgot to mention, and I'm sorry for it. So yeah, that's the entire thing. Okay, anyways, it works out, I guess. So as I was saying, that it has this triangular impression as well as this notch in its lower end. See, do you see that this part is actually notched? See, notched, right? This notch is called the ulnar notch. So ulna had a notch in its upper side known as the radial notch for kind of articulating with the neck, head neck of the radius, right? Ulna had that, whereas radius has a notch which is the ulnar notch, which will be useful for the wrist joint articulation. We'll talk about it later. So that's again another interesting feature. This is the dorsal or the posterior surface of the lower end. Posterior surface is very interesting because, as you can see, it is very rough and it has a number of these ridges. These ridges, they actually, what they are is, they are passages for the tendons of the extensor compartment. There are total 6 compartments for the extensor retinaculum muscle tendons for passage. 4 of those compartments reside over the lower dorsal surface of radius. 5th one resides in between the articulation of the radius and ulna. 6th one resides directly over the ulna. Alright. Out of all these, rough impressions and, passages and all of that, this median, I might say, tubercle, it's very prominent. Do you see? This is known as the dorsal tubercle of Lister. The dorsal tubercle of Lister. Alright, this is a very prominent tubercle on the dorsal surface, somewhat middle or median, right? It's somewhat middle. Okay. So that's medial surface, the anterior surface, the dorsal surface, the posterior surface, the lateral surface, already mentioned with the styloid process, and the inferior surface. as you can see, the inferior surface, it is pretty interesting again, because this will be articulating with the wrist bones, typically scaphoid and lunate. How so? See, if I place my pencil over here, can you see that there is a division, with this part being triangular and this part being roughly quadrangular? Well, that is exactly what happens. This triangular, rough triangular impression, this will be actually articulating with the scaphoid, whereas this quadrangular part will be articulating with the lunate bone. Okay, so that will form the basis of the wrist joint, which we'll talk about again later. Now, there are a list of these muscle tendons which will be going on through these compartments, and it's pretty actually hard. I mean, the first compartment actually would be in between the styloid process over here. See, this is the styloid process, right? In between this yeah, do you see this? This is the lower part of the anterior margin. The lower part of the anterior margin and the styloid process. In between them, there will be the first compartment. In between the styloid process and another tubercle which is somewhat lateral to the dorsal tubercle of Lister, or rather, in between the dorsal tubercle of Lister and the styloid process, there will be the second compartment. In between a little medial to the dorsal tubercle of Lister, there will be the third compartment, and a little, you might say, lateral to that. We are going lateral, right? No, we are going medial. I'm sorry. A little medial to that, there will be the fourth compartment. Again, in between the junction, there will be the fifth compartment, radius and ulna, and on the ulna itself, in between the head and styloid process of ulna, there will be the sixth compartment. Now, different muscle tendons they've actually passed. For example, from the first muscle compartment, that will actually give passage to the tendons of the, do you remember what I said, anatomical sump box? Yes, those two tendons, the abductor pollicis longus and the extensor pollicis brevis. Just like that, the second one will be giving passage to some other tendons, the extensor digitorum longus and the extensor digitorum brevis, I guess. And then the third compartment again will be giving passage to the extensor digitorum, something like that. The fifth compartment will be giving passage to the extensor digiti minimi. Sixth will be giving passage to extensor carpi ulnaris, and the fourth compartment was a little big, right? It gives passage to extensor digitorum, extensor indicis, the posterior interosseous nerve, and the anterior interosseous artery. I guess this is the order, but I would recommend that you go through your textbook and not take my word, because I'm solely reliant upon my memory here. So I would say that you go, at least for that section, go through your textbooks. All right, do not take my word for it, but at least I'm giving you an orientation of how the compartments are, and roughly what the tendons might be. Lastly, let's talk a bit about the clinical anatomy of the radius. There's not much to talk about, but one thing I would say is that radius, again, just like any long bone of the arm or forearm, can get fractured when there is a fall on the outstretched hands like this. And typically what happens is that the distal fragment, this might get displaced anteriorly meaning downwards. So if this is the radius I'm holding horizontally, this side is the anterior side and this side is the posterior side. See the rough dorsal tubercle of Lister. So this should be the dorsal side, this should be the anterior side. So the distal part can get displaced anteriorly over here. Then the fracture is known as Smith's fracture. Posteriorly, however, if it actually is displaced posteriorly and somewhat behind, it is known as Colles fracture. All right. So this is somewhat the clinical anatomy. Obviously, there are other types of fractures as far as the radius is concerned, but we will not be going into details of that. Now, another clinical anatomical problem that may arise typically in children is something called the subluxation of the elbow joint, which is that since the annular ligament is actually holding the head and neck of the radius, or the upper end of the radius, and there is no strong capsule or muscle to actually hold it correctly, it's just a band of ligament, a ring shaped band of ligament holding it. Sometimes in children, typically what happens is that when there is sudden pulling or outstretching of the forearm, what happens is that the radius may slip from the annular ligament and may come out of the annular ligament, which is known as subluxation. It is very, very easily fixed by any clinical physician. There is a particular maneuver for that, and I would recommend that you watch a video for that. I have watched many of those. They are very, very easy to perform, I guess, but they are also pretty painful for the children. So yeah, that's subluxation at the elbow joint, and that is also a clinical anatomical feature of the radius bone. So with that, I guess we've complete the entire radius anatomy. I hope you found something of importance from this entire discussion that we had. If you did, well, thank you very much. If you did not, I'll try harder next time, and see you again. Thank you.